A very good evening to respected faculty, my colleagues and juniors. Today I'll be presenting a seminar on the topic factors deciding the extent of neck dissection in oral cancers. Oral cavity cancer is the 16th most common cancer globally, with India having an incidence of 1,43,759 cases, accounting for 1/3 of the global burden. It is the most common cancer in terms of incidence and mortality in men in India, according to Globocon 2022. Central node metastasis is the most important prognostic factor in head and neck squamous cell carcinomas, with even a single positive node upstaging the disease to stage 3 and reducing the survival by up to 50%. The history of neck dissection reflects a very dramatic evolution from the early attempts made by
please go slowly. Excuse me, please go slowly. If you have too much to speak, then you have to modify your presentation. Go slowly.
History. Yes.
And also,
history
you have written everything on the slides. You have written everything on the slides. You have written paragraphs.
And yes, we have told you so many times that only bulleted points should be there. Your English is good enough to make a sentence out of it. Chalo abhi.
History of neck dissection reflects a very dramatic evolution from the early attempts made by Theodore Wadsworth and Henry Tenton to the seminal work done by Trial in 1906 that standardized the procedure of radical neck dissection, which was further validated by Hayes Martin. This procedure of radical neck dissection remained the standard for the next 3 decades until a shift was seen done by the seminal work by Brota, which showed that a modified radical neck dissection was ontologically as safe as a radical neck dissection, reducing the morbidity of the surgery without reducing ontological safety. Coming to level of neck nodes, the neck nodes can be divided into 6 groups. Level 1A, where the superior border is the symphysis of mandible, inferior is the body of the hyoid, medially and laterally it is bounded by the digastric muscles. Then 1B, again the superior border is the mandible, inferior is the posterior belly of the digastric muscle, medially it is by the anterior belly of the digastric muscle, and posteriorly it is by the stylohyoid muscle. Level 2 is divided by the spinal accessory nerve into 2A and 2B. 2A, the superior border is the skull base, inferiorly defined by the inferior border of the hyoid bone, medially by the stylohyoid, and laterally by the spinal accessory nerve. 2B, the superior border again is the skull base, inferiorly by the inferior border of the hyoid, medially by the spinal accessory nerve, and laterally by the lateral border of the SCM. Level 3 is defined superiorly from the inferior body of the hyoid, inferiorly up to the inferior border of cricoid cartilage, medially by the lateral border of sternohyoid, and laterally by the lateral border of the sternocleidomastoid. Level 4 is defined superiorly by the inferior border of cricoid up to the clavicle, medially by the lateral border of sternohyoid, and laterally by the lateral border of the sternocleidomastoid. Level 5 is divided by the superior and the inferior belly of the omohyoid muscle. 5A superiorly is at the apex of convergence of SCM and the trapezius muscle, inferiorly by the lower border of cricoid, medially by the posterior border of the SCM, and laterally by the anterior border of the trapezius muscle. 5B is defined from the cricoid to the clavicle, medially by the sternocleidomastoid's posterior border, and laterally by the anterior border of the trapezius muscle. Level 6 ranges from the hyoid bone up to the suprasternal notch, bounded on both sides by the common carotid artery. The neck dissection can be classified according to the consensus given by the American Association of Head and Neck Surgeons. It is based on the extent of limb node removal and the preservation of key non-lymphatic structures, which include spinal accessory nerve, the internal jugular vein, and the sternocleidomastoid muscle. It defines mainly 4 procedures. One is the radical neck dissection, where all the level 1 to 5 nodes are removed and none of the non-lymphatic structures are preserved. Then we have modified radical neck dissection, where the extent of removal is from level 1 to 5, with preservation of 1 or more non-lymphatic structures, on the basis of which it is further classified into 1, where the cranial nerve 11 is preserved, 2, where the nerve and the IGB is preserved, and 3, where all 3 non-lymphatic structures are preserved. Then we have selective neck dissection, which is targeted levels are removed. It includes supraomohyoid, which is level 1 to 3, then lateral neck dissection, levels 2 to 4, and central, which includes level 6. Here, all 3 non-lymphatic structures are preserved. And then we have extended radical neck dissection, which includes all the 1 to 5 levels of RND, plus the additional groups like retropharyngeal or the parotid limb nodes. It includes a removal of all the RND structures, plus additional non-lymphatic structures like the carotid artery or the external carotid artery or the varus nerve can be sacrificed. Coming to complications of neck dissection, it can be divided into immediate, intermediate, and late complications. In the immediate complications, we can have bleeding, airway obstruction, increased ICP as a consequence of ligation of IJV, then carotid sinus syndrome, where the carotid baroreceptors can be injured because of traction or electrosurgical or electrical energy at the bifurcation of common carotid, which can result into immediate intraoperative or postoperative bradycardia, hypotension, or even syncopal attacks. Then nerve injuries, which includes injury to spinal accessory nerves, marginal mandibular, hypoglossal nerve, then the brachial plexus or even the greater nerve can be injured. Then intermediate complications include seroma, tilus fistula because of injury to the thoracic duct, infection, wound disease, carotid artery rupture, flap failure, or even fistula formation. In general complications, we can have basal collapse, bronchopneumonia, and DVT owing to the presence of cancer or comorbidities in such patients. Most of these patients are smokers and also because of the long duration of the surgery. Late complications can include recurrence, distal metastasis, as well as formation of hypertrophic scars in the neck, which then restricts the movement of the neck to a certain extent. The factors which determine the extent of neck dissection includes the clinical nodal status, which is based on facial examination and imaging, the primary tumor characteristics, which will include tumor subsite and proximity to midline, tumor stage, the depth of invasion, the PNR and the LVI status, the date of differentiation, and the worst pattern of invasion. Can be western nodal extension and certain intraoperative findings like the presence of multiple positive nodes or a pathological level 2A node. Coming to tumor location, level 1, 2, and 3 are the most commonly involved oral cancers. Metastasis to level 4 and 5 are rare, with level 4 being 9 to 20% in most of the studies, and level 5 being 2 to 4% in majority of the studies. In majority of the studies, the oral cancers show a pattern lymph node metastasis. Strip mets are rare, though it is documented with tongue and floor of mouth cancers. Cervical involvement below level 3 was less than 5% in majority of the studies, which increases substantially to 7.3% if only clinically positive nodes were seen. Upon multivariate analysis, certain independent predictors for lymph nodes were identified, which included depth of invasion, pathological grade, the T staging, and the morphological type, with ulcerative lesions showing much more chances of a lymph node match as compared to ulcerative lesions. On the basis of tumor location, oral tongue, the most common level being level 2, followed by a level 1B. It has higher chances of strip nets as compared to other subsites. Then floor of mouth, the most common level is level 1B. Level 1 to 3 are the other primary sites which can be involved. For buccal mucosa, the most common level is again level 1B. Level 1 and 2 usually gets involved. In buccal mucosa lesions, the chances of involvement beyond level 3 is very low. In majority of the studies, lower alveolus, the gingiva involvement showed the highest incidence of positive nodes. And also, there was fewer chances of lymph node involvement beyond level 3. For hard palate, the anterior aspect usually drains in the submandibular glands and the posterior in the deep cervical glands. And for RNT, while level 1B and level 2A were the most common.
What is MC? M/C?
Most common.
Now, this is a new short form you are invented or what? Please use only standard nomenclatures.
For depth of invasion is a histopathological measurement that quantifies the vertical extent of cancer spread. It is based on stain. Histopathological examination is a gold standard for diagnosing it. It is based on stained tissue slice with the reference points being the adjacent normal basement membrane. Now, DOI is different from tumor thickness. Where in tumor thickness, we have to calculate the entire thickness from the surface of the tumor up to its extent. In DOI, it has to be measured from the normal basement membrane up to its maximum location of invasion. It can be measured preoperatively using an intraoral ultrasound or other imaging. For T1 or T2 N0 oral squamous cell carcinomas, the real controversy lies whether to perform an elective net dissection or a wait and watch policy followed by a therapeutic net dissection. And DOI is the most significant reliable parameter for predicting occult regional nodal involvement, superseding tumor size alone. Now, multiple studies have reached a critical cutoff of 4 mm DOI for strongly recommending elective net dissection, as the risk of further metastasis exceeds more than 20% and helps to identify the minority of patients, T1, T2 patients, who truly require an elective net dissection. For clinically positive net, on the other hand, DOI is fundamental to determine the T stage and the overall prognosis. But the choice between a supraormoid and MRND is predominantly guided by the clinical end stage and perceived risk of disease in the lower neck lips, and not directly by a DOI cutoff. Now, certain studies which have evaluated DOI, there was a review of literature done by Pentero published in 2005 in the Head and Neck Journal, which said that DOI is a very reliable predictor for metastasis and survival. But the consensus on consistent cutoffs varied from 1.5 to 10 mm in different studies. Another retrospective ROC analysis was done by Van Lescott, published in 2020, which said that 4 mm is a very optimal cutoff. The metastasis risk was less than 1.4% for depth of invasion of less than 4 mm, and strongly validates elective net dissection to be done if the depth of invasion was more than 4 mm. Another retrospective study was published in Front Oncology in 2021, which said that the risk was more than 20% with cutoff of 4.3 mm. which supports again that elective net dissection for depth of invasion more than 4 mm, and wait and watch policy is viable for certain tumors with a depth of invasion less than 4 mm. Coming to PNI and LVI, perineural invasion is a histopathology.
Akshay, hold on here. Just don't
ma'am.
keep running. What kind of studies were these? Retrospective, prospective, case control?
Ma'am, the first study was a review of literature, ma'am, and the other 4 studies were retrospective studies.
So you have to include that also. I mean, you tell that. I mean.
Yes.
Okay.
For perineural invasion is a histopathology of cancer cells invading into, around, or through the nerve sheath. Now, it is a key mechanism for tumor spread, and it is a common finding reported in approximately 30 to 50% of oral squamous cell carcinomas, and also an independent risk factor for poor overall survival and disease-specific survival. Now, it is strongly associated with a higher incidence of lymph metastasis, particularly occult mets in CN0 patients. Primary lymphovascular invasion is the presence of tumor cells within an endothelial-lined lymphatic or blood vessel. It is an indicator for aggressive tumor behavior and a primary route for metastasis. It is a critical predictor for cervical lymph nets and subsequent regional failures. A concept of double positive exists where both the PNI and LVI is positive, which is a potent predictor for distant mets and a predictor for extremely poor survival in advanced T3 and T4 tumors. In case of clinically native net, PNI and LVI are fatal predictors for occult mets and strongly warrants proceeding with the elective net dissection over observation to mitigate the recurrence risk in future. In case of clinically positive net, PNI and LVI indicates highly aggressive tumor biology and associated with ENE status and mandates the use of intensified adjuvant therapy. Although there's no clear consensus regarding the extent of net dissection, whether a supraomohide or an MRD should be done in case of its positivity in a positive net. A double positive status again stratifies patients in the highest risk group for both local regional as well as distant mets, necessitating aggressive surgical and adjuvant treatment protocols. Certain studies which were done on PNI and LVI, there was a retrospective cohort study which was published in 2015 by J.F. Jardim et al., which showed that PNI is a very significant independent predictor for poor survival in advanced oral squamous cell carcinomas, necessitating comprehensive surgical clearance and adjuvant therapy intensification to control the regional disease. Similarly, a meta-analysis of 74 studies, including 27,000 patients, was published in Cancers in 2024, which said that PNI is a confirmed critical prognostic factor for local regional recurrence, validating its use as an indication for surgical net intervention, that is a net dissection, to prevent regional failure. Next parameter is extranodal extension, which is defined as a disruption and penetration of tumor to the entire thickness of lymph node capsule. It can be classified in 3 ways. First is the pathological EME. Now here HP is a gold standard for determining EME. It is subdivided into minor, which is less than 2 mm of extension beyond the capsule, and major, which is more than 2 mm of extension. Then we have imaging detected EME, which is determined via pre-treatment radiological imaging. MRI or a intraoral ultrasound can be used. It is classified into grade 1, which is confined to perinodal fat. Grade 2, which presents a matted nodal mass, and grade 3, which invades the surrounding structures like muscles, nerves, or skin. Then clinical EME, where unambiguous evidence of gross EME on clinical examination, that is involvement of skin or the musculature, exists. And usually a clinical EME will correspond to a grade 3 of IME. Now, EME reduces, associated with reduced overall survival, there's increased risk for distant mets and lower rates of local regional control, and there's a need for a more intensive adjuvant treatment following surgery. There was a retrospective study conducted by Wiesman and et al. In 2016, where 245 PN plus oral cavity patients were evaluated, and it concluded that ECS can be divided into a major and minor based on the extension of disease beyond the nodal capsule, the cutoff being 1.7 mm, and showed that minor ECS with cutoff of less than 1.7 mm and no ECS had a similar disease-specific survival as compared to a major ECS, which found it to be an independent predictor of poor disease-specific survival. Similarly, a retrospective study conducted by Landelli et al. Of 565 T1, T2 oral cavity patients with adverse net effects status like EME or multiple nodes concluded that no survival difference between SOHND and MRND was there in EME positive patients with a P of more than 0.44. And SOHND is ontologically safe even with EME. EME primarily impacts distant failure, which has to be addressed by further adjuvant therapy or CCRT rather than the extent of net dissection. Now, historically, presence of EME suggested the need for an MRND due to high risk and aggressive nature of the disease. In light of new evidence, it can be concluded that the choice between SOHND and MRND can't be solely based on the presence of EME. High-risk prognosis of EME is driven primarily by the risk of distant failure, which is addressed by intensified adjuvant chemoradiotherapy and not by including level 4 or level 5, where the risk of involvement is very low. But further RCTs are required to further validate whether in the presence of EME, a complete MRND always is mandated or not. The next parameter is tumor differentiation grade, where oral squamous cell carcinomas are divided into 3 grades based on WHO grading system. The parameters considered include resemblance to normal cells, keratin production, neutrocytoplasmic ratio, and mitotic activity. Poorly differentiated tumors usually has low or none resemblance to normal cell. They have minimal or absent keratin production. They have a high neutrocytoplasmic ratio with a large pleomorphic nucleus with minimal cytoplasm. And the mitotic activity is high with numerous or often atypical mitosis, indicating rapid proliferation and thereby making it a poor prognosis. Certain studies done on tumor differentiation grade. There was a prospective observation study which was done and published in South Asian Journal in 2023, which said that in N0 patients, poor differentiation was a statistically significant independent risk factor for the presence of occult mets, supporting that elective net dissection should be done. Similarly, another retrospective cohort study published in 2021 showed that in N0 patients, poor tumor differentiation was identified as a major risk factor for occult nodal mets. And thereby in T1 N0 tumors with depth of invasion less than 3 mm, a staging net dissection should be considered in case a poor differentiation is present for the primary tumor. Similarly, retrospective study in 2022 showed that presence of poor differentiation and other adverse features like DOI or PNI indicates increased risk of nodal mets, but still a selective net dissection with sparing of level 5 is an option for advanced tumors. In N+ disease, grade indicates the need for adjuvant therapy rather than the extent of primary net dissection. So in N0 tumors, if N0 net, if poorly differentiated tumors are positive, elective net dissection is preferred. As in case of N+ disease, grade cannot solely be used to differentiate between the need of extent of a SHND or a MRND. But linearly native net, poorly differentiated cancers have shown a high incidence of occult mets compared to well-differentiated, moderately differentiated lesions, the risk being more than 20%, and they were mandating the need for an elective net dissection. However, the extent of dissection of supraomo height is based on the subsite and the depth of invasion rather than grade of lesion. On the other hand, for clinically positive net, MRND or a comprehensive SND is often the standard of CN+ disease. Poorly differentiated is indicated for higher regional disease burden and greater likelihood of multiple level involvement and EME, but still can't be used solely to get the extent of net dissection. Rather, it mandates the use of post-operative adjuvant treatment rather than the extent of initial net dissection done during the primary surgery. When to do a contralateral net dissection? Oral squamous cell carcinomas with a rich submucosal lymphatic plexus with free communication across the midline. Primary concern is the risk of occult contralateral net mets, which can be missed, with reported rates varying between 0.9 to 36%. Elective net dissection is generally accepted for tumors approaching or crossing the midline. Risk factors for contralateral occult mets includes the tumor location, which is increased with carcinoma of tongue and floor of mouth. In advanced stage, T-stage, T3 and T4 tumors, and presence of certain historical findings like PNI or poorly differentiated carcinoma. In the contrasting view on the location of tumor, a study was done by Matty et al., but it was a single-center retrospective study with a very small population of 98 patients with oral and oropharyngeal carcinomas with clinically native contralateral net, which concluded that midline involvement was not a significant risk factor for occult contralateral net mets. Rather, location of the primary, like oropharyngeal or the end status, presence of multiple nodes or N1, was associated with a higher risk of occult contralateral mets. In CN+ disease, high-risk features for contralateral mets include ipsilateral metastasis is one of the most important predictor of risk to contralateral net. The rate of occult contralateral net mets can be as high as 21%, with the risk increasing to 50% in case the ipsilateral net has multiple level lymph node involvement. The end status of more than N1 significantly increases the risk of contralateral nets with the odds ratio of 3.41. Extra capsular spread also increases the risk with a worsened overall survival. And coexisting PNI, a combination of midline involvement with PNI, is also highly predictive of contralateral net mets. For management, for midline region tumors, elective net dissection or RT is strongly suggested for high-risk patients. For surgical option, initial bilateral net dissection may offer better control. And for moderate to high-risk patients, contralateral net should always be included in the radiation field. Certain studies on the contralateral net dissection, there was a systemic review which was done and published in PLAST etc. West in 2016, which showed that contralateral net mets significantly reduces the survival. Predictors of contralateral net mets included midline involvement, T-stage, presence of ipsilateral metastasis, as well as tumor location like floor of mouth and base of tongue and tongue base. When should level 2B dissection be done? The primary risk of doing the level 2B dissection is injury of the spinal accessory nerve, which is a key anatomical landmark for level 2B. Dissection requires nerve traction and hanging, which can cause neuropathia or permanent trauma, giving rise to a shoulder syndrome, in which the patient will have a chronic pain, restricted abduction, or even a frozen shoulder. Level 2B can be avoided safely in elective N0 neck dissections for most oral cavity cancers. Studies consistently show a very low rate of occult mets in CN0 neck. Preserving level 2B avoids unnecessary morbidity without compromising ontological safety. Indications for doing a level 2B includes when you are doing a therapeutic neck dissection for a positive neck. Then in case level 2A, which is referred as a gatekeeper level, is positive, either clinically, visually, or upon frozen section. Then high-risk primary sites like tongue, RMT, or the floor of mouth. And in case the patient has advanced end stage, N2B, N2C, or confirmed extracapsular spread is present. Studies on level 2B dissection. There was a non-randomized prospective observation study, which was published in 2016 in the Indian Journal of Surgical Oncology, which said that level 2B dissection can be avoided in N0 nets. But on the other hand, for N+ nets, it should always be cleared. Similarly, a prospective study of 470 patients published in 2014 said that selective net dissection, including level 1 to 4, was adequate for majority of N+ nets. Level 2A positivity was an independent predictor for both level 2B and level 5 nets, and being positive, both these sites should be cleared. Worst pattern of invasion, it is a histopathological grading system used for oral squamous cell carcinoma to classify microscopic appearance of tumor at the invasive front. There is an important prognostic factor and reflects tumor aggressiveness and also the potential to spread. It can be graded into 1 to 5. The worst pattern of invasion, grade 4, grade 5, usually is aggressive or the infiltrative pattern. It is characterized by tumor satellites distant from the main tumor mass, and is always a high risk of occult nodal nets and poor prognosis. So for CN0 nets, if WPI is less than 4, and other favorable factors like DY is less than 4 mm, watchful waiting or sentinel node biopsy can be preferred over elective net dissection. On the other hand, if WPI is 4 or 5, there is a significant risk of occult cervical nets, and elective net dissection should always be recommended. But for CN plus disease, WPI points towards increased aggressiveness. However, the extent of dissection and the need for adjuvant treatment is varied by accumulation of other factors and not solely by the WPOI status. There was a retrospective cohort study which was published in 2005, including 292 patients, which suggested that high-risk histology, including WPOI5, was a strong predictive of poor local disease-free survival as well as overall survival. WPOI5 is a key prognosticator suggesting the need for aggressive management of the primary site as well as the neck. Similarly, a retrospective feasibility study, which was published in 2023 of 228 PT1 patients, said that WPOI5 predicts occult cervical nets in PT1 patients. It can be accurately identified at frozen section, allowing surgeons to perform an elective net dissection at the time of primary surgery, and thereby minimizing the risk of missing out on these occult net nets. Neoadjuvant chemotherapy. Patients receiving neoadjuvant chemotherapy for locally advanced, technically undissectable oral cavity cancers have demonstrated an overall survival benefit for patients who are able to undergo surgery for both the primary disease as well as neck, as demonstrated by studies conducted by Patil B.M. et al. And Mishra B.A.K. et al. A prospective study conducted by Dhanawat A. et al., which was a 10-year outcomes of technically undissectable oral cancers with neoadjuvant chemotherapy, published in the Journal of Clinical Oncology, demonstrated that 929 patients out of 3,200 patients were able to undergo surgery after neoadjuvant chemotherapy response. However, 36.4 of these operative specimens had EME, highlighting that even after a good clinical or radioactive response, less aggressive net dissection would not be justified in these advanced lesions. Therefore, neoadjuvant chemotherapy can be used to make comprehensive surgery possible in technically undissectable lesions, but not as a means to de-escalate the required extent of net dissection, primarily to reduce response of chemo on neck nodes and persistent risk of ANE and residual microscopic disease in advanced clinical status of the original tumor. There's an overview of comparative net dissection studies. There was a landmark trial done by the Brazilian Head and Neck Cancer Study Group, which was a prospective multi-institutional randomized trial of 148 patients, T2 to T4 CN0 patients, which recommended that supramohide net dissection recommended a standard elective treatment for N0 nets. The difference in survival rates was similar, and SOHND was significantly lower complication rate as compared to MRND. Similarly, a retrospective study, which was published by Schiff B. et al., had 220 patients of squamous cell carcinoma of the oral tongue who underwent net dissection, and it also concluded that selective net dissection may be sufficient for many CN plus patients. However, for CN plus or PN2, there was a difference in lesion control favored MRND or RND, suggesting some benefit from more aggressive treatment. The retrospective cohort study was published in 2014, which had 143 PN plus patients of oral squamous cell carcinoma of tongue and floor of mouth, and all of these patients received adjuvant radiotherapy. It said that selective net dissection plus adjuvant radiotherapy is a strategy of high efficiency and a minor morbidity for selective PN plus patients. There was no significant difference in 3-year net control rate, and selective dissection had significantly fewer complications. Similarly, a meta-analysis done by Liangle et al., published in 2015 in Oral Oncology, also concluded that selective dissection in conjunction with adjuvant therapy had comparable clinical outcomes compared to comprehensive dissection. There was no significant difference found for regional recurrences, disease-specific survival, or overall survival. Retrospective study by Shimura et al., which had 68 patients only of PN1 to PN3 disease, concluded that selective dissection for PN plus oral squamous cell carcinoma is appropriate for those up to 2 positive lymph nodes, with lymph node size being less than 3 cm without AME, and provided adjuvant radiotherapy was given to them. Number of positive nodes was a more important independent predictor for overall survival and disease-specific survival. If you compare suprahomohide net dissection, MRND, and CN0 net, for regional control and survival, suprahomohide net dissection, there were similar rates of recurrence and overall survival compared to MRND for T2 to T4 lesions. It can be recommended as standard elective treatment. The extent typically involves level 1 to 3, but it can include level 4 or target lymph node levels at risk. Suprahomohide net dissection had significantly lower complication rates and was favored due to less functional and cosmetic defect. Recurrence rate, there was lower net recurrence rate, 2.38% in one retrospective comparison. Also, with suprahomohide net dissection, bilateral elective net dissection was more feasible, improving the oncological safety by avoiding late mets on the contralateral site. In comparison, suprahomohide versus MRND in CN plus lesions, in terms of regional control, there was comparable outcome in disease-free survival, overall survival, when suprahomohide net dissection was combined with adjuvant therapy. Adjuvant therapy was always considered in case of multiple positive net nodes, which were independent predictive factor for poor overall survival and disease-specific survival, and also in case extracapsular spread was present. Selective net dissection was associated with less morbidity, even when adjuvant therapy was combined with it, and a more rapid post-op recovery. And selective net dissection, including level 1 to 3, is appropriate for PN plus oral squamous cell carcinoma with up to 2 positive nodes, less than 3 cm in diameter, without EME, and provided adjuvant therapy was given to. Management of clinically N0 net in early stage oral squamous cell carcinomas. The dilemma is that early stage oral 1 to 2 N0 lesions often present with N0 net, however, they have a significant risk of 20 to 40% of oral lymph node mets. Incorrectly managing the net can lead to worse outcomes, as nodal status is the most important prognostic factor. Management option includes a wageful waiting, and therapeutic net dissection if nodes becomes clinically or radiologically positive. Sentinel lymph node biopsy, where you remove only the first echelon nodes, and further net dissection depends on their positivity or negativity. And then elective net dissection, that is to prophylactically remove lymph nodes from specific net levels at the time of primary tumor, regardless of the clinical findings. Clinically N0 for early stage oral squamous cell carcinoma, when we compare watchful waiting with plus TND, the sentinel lymph node biopsy, and elective net dissection, the indication for watchful waiting includes a depth of invasion less than 3 mm, well-differentiated lesions, significant comorbidities for the patient, or the patient preference. Contraindication usually is a depth of invasion of more than 4 mm. It is usually a cutoff where elective net dissection or sentinel biopsy should be done. PNR, LVI positive, poorly differentiated lesions, and unreliable follow-up. The pros involves avoids upfront surgery and the associated morbidity, whereas cons can be a risk of delayed METS diagnosis, potentially worse survival because majority of the time when the diagnosis of a relapse is made is at the higher level. Intensive follow-up required for watchful waiting and patient anxiety. The risk of morbidity and mortality is risk from delayed, often more extensive therapeutic net dissection with or without adjuvant treatment upon relapse. Outcomes, wakeful watching has an inferior overall survival, disease-free survival, disease-specific survival as compared to elective net dissection or sentinel node biopsy in several meta-analyses. Relapse often at a higher stage with poor prognosis. For sentinel node biopsy, the indication can be a T1, T2, N0 lesion. The primary should be an accessible allocation and available of expertise in technology at the center. Contraindication can be an N plus net, a prior net surgery or RT, which alters the drainage, allergy to certain dyes being used, and the presence of midline tumors. Those can be at-risk staging. It avoids net dissection in 70 to 80% of this cohort. A less shoulder dysfunction identifies aberrant drainage and oncologically safe. Once can be, it requires expertise. It has a false negative rate of 5 to 15%, but a salvage surgery has to be done. Then potential for 2 surgeries and a longer learning curve associated with low morbidities, and and the outcome is non-inferior to overall survival, disease-free survival, disease-specific survival, and the remaining risk compared to elective neck dissection. Elective neck dissection, the indications can be most of the T1, T2, N0 lesions, especially with high-risk features like a DY of more than 4 mm or PMI positive. Then when neck access is required for reconstruction, and when the follow-up for the patient is unreliable. Contraindications can be significant comorbidities or very low-risk tumors. The advantage is that it is a single procedure for staging and treatment. It removes occult nodes 20 to 40%. It has a proven survival benefit over awaiting, and it is established standard which is widely accepted. The disadvantage being it is over treatment in almost 70% of this cohort, higher upfront morbidity of shoulder or nerve injury, longer hospital stay, and high initial cost. For morbidity and mortality, there's definitely upfront surgical morbidity, shoulder dysfunction, nerve injury, vessel injury, and low surgical mortality. Outcomes, it has a superior overall survival, disease-free survival, disease-specific survival, and lower remaining risk as compared to watchful waiting, and comparable oncological outcomes can be seen as compared to sentinel lymph node biopsy in this cohort. A summary for studies for C and net management. A study was done by Deepus et al., which was a randomized controlled trial of 500 T1, T2, and 0 patients. It was a landmark trial which concluded that elective net dissection resulted in higher overall survival and disease-free survival compared to therapeutic net dissection. Similarly, systemic and meta-analysis was done by Takeda D et al., which was published in 2025, which again concluded that END favored overall survival and disease-free survival and local regional control versus watchful waiting. But certainty of evidence was low. Increased shoulder dysfunction was seen with elective net dissection. Another RCT study was done, which was referred as the Sentinel trial, which was published in 2020, which showed that sentinel biopsy showed similar oncological outcomes compared to elective net dissection, establishing its non-inferiority. And a prospective observation multi-center study, including 415 patients, published in 2015, the SEN trial, which also showed that sentinel biopsy is a reliable and safe oncological technique for staging C and 0 nets in T1, T2 oral cancer with a sensitivity of 86%, a negative predictive value of 95%, and a disease-specific survival of 94%. An area of active research is molecular analysis to predict the presence of oral lymph node metastasis in C and 0 nets, moving beyond the traditional pathological factors. It includes genomic signatures like 3q, 8p20 subtypes, which strongly predict cervical lymph node mets and the need for elective net dissection. And certain gene expression signatures like 4-gene panel are highly predictive of mutant spread in oral tongue. And reduced expression of E-cadherin and integrin B6 is also identified as key indicators of increased metastatic risk due to altered cell adhesion and invasion. Now, these signatures can be used in the primary tumor tissue to predict the likelihood of occult net mets in T3 N0 patients, guiding the decision whether a net dissection should be done or not. However, it requires more validation before it can be used in clinical practice. Certain signatures include cancer testis antigens, which includes LY6K, media A3, SET55, and ATAD-D2, then cell adhesion molecules like E-cadherin, integrins like integrin beta-6, which is elevated expression is frequently found in patients with metastatic lymph nodes, then matrix proteinase pathway, which correlates with lymph node metastasis in oral squamous cell carcinoma, and certain tumor suppressor genes or oncogenes like CDKN2A, which is also associated with lymph node metastasis, or when often lost or mutated.
35 minutes are over, Doctor. You were allotted only 25. Do you rehearse your timings or not? This is your last slide.
Yes, ma'am.
Please rehearse your timings.
Important determinants for extent of net dissection included depth of invasion, poor differentiation. LBI PNI, however, was difficult to assess in biopsy specimens in multiple level lymph nodes, and ENE, which was the most important deciding towards the need for intensive adjuvant therapy. For T1 N0 lesions, if PNI LBI was negative and well-differentiated multi-differentiated lesions, a DY of less than 4 mm, sentinel lymph node biopsy was better as compared to elective lymph node dissection. Wait and watch policy can also be considered here. For PNI LBI positive poorly differentiated tumors, elective lymph node dissection was preferred over a sentinel lymph node biopsy. Level 2B can be avoided in T1 N0 lesions, provided level 2A frozen section is done, it comes out to be negative. Then for T2 N0 lesions, for PNI LBI negative and well-differentiated, multi-differentiated lesions, ELD was considered to be equivalent to sentinel lymph node biopsy. In case PNI LBI was positive or a poorly differentiated tumors were there, ELD was supposed to be superior as compared to sentinel lymph node biopsy. For T3, T4A, N0 lesions, elective lymph node dissection, supraomohyoid neck dissection, to consider level 4 for certain locations like tongue or floor of mouth. In case of T1 to T4A, N1, N3 lesions, extended supraomohyoid level 1 to 4 should be included. We need to consider MR entry in case of LVI, PNI positivity, poor differentiation, level 2A positive, multiple level nodes, and positivity of EME. Indications for bilateral neck dissection included the N2C tumors, tumors reaching or crossing midline, presence of high-risk features like T3, T4 tongue tumors, floor of mouth lesions, presence of PNI, poorly differentiated tumors, as well as multiple ipsilateral presence of nodes. This is the NCCN guidelines for current NCCN guidelines.
Okay. The topic is open for discussion. Especially the residents, they have to ask whether they understood, because the topic was something else and Akshay has talked about something else. What was the topic, Akshay?
The extent of neck dissection, parameters which decide decision making.
Decision making. And you have been talking most of the time about the adjuvant therapy and survival. You have talked more about the predictors of adjuvant therapy rather than the predictors of level of dissection or the extent of dissection. Residents, anybody want to ask? Third years?
My question to Akshay is there any role of frozen section in determining extent of neck dissection or level of neck dissection?
Frozen section can be used in case of for both the primary as well as the neck lesions. For neck lesions, in case we are doing a sentinel node biopsy, then frozen section has to be done. It comes positive, then we have to go for a comprehensive neck dissection. Further, in case we are doing the supraomohyoid dissection, we can do a frozen section. And if that comes positive, then we can go towards a more comprehensive neck dissection. In case of primary, we can find parameters like depth of invasion or PNI or LVI, which can guide towards the need for a elective node dissection in N0 neck.
Okay.
Anyone else? Yeah, Fred.
Okay. What is there a role of PET scan in deciding the extent of next dissection?
PET scan can be used in case of clinically N0 neck. It has a high negative predictive value, but then its limitation is that it has a very low positive predictive value. Then it can also, it is not as sensitive for micrometastasis. And sometimes reactive lymph nodes or lymph nodes because of inflammation can also be highlighted, which can drive towards a net dissection, which may not be required. So solely on the basis of PET CT scan, we cannot decide in our N0 net whether we should do a complete net dissection or not.
Akshay, why level 2A is known as a gatekeeper of lymph nodes?
Usually, in a majority of the studies, involvement of level 2A has shown to be risk factor towards the involvement of level 2B as well as level 5. So in case there's a dilemma whether the extent of net dissection, we can do a frozen section for level 2A, or if it is if it is positive clinically or on imaging, then only we can go for a level 2B and a level 5 clearance in case of N0 nets. But in case of nets which have a positive lymph node, level 2B should be clear.
Akshay. Hello.
Yes, sir.
Akshay. Yeah. How many of the factors you discussed that affects the extent of lymph nodes? Do we know beforehand before going to surgery so that we can be our extent of neck dissection upon?
So we,
either biopsy or from the imaging. How many of the factors you discussed do we know beforehand?
So from biopsy, we can know the depth of invasion and the differentiation of tumor. Problem
you
with
cannot
LV and
depth of
problem with
invasion. You
LV
cannot know the depth of invasion from their simple biopsy.
from imaging, so we can find out the depth of invasion, sir. MRI is thought to be very sensitive for depth of invasion.
Imaging that cannot give you a clear exact extent. It can be a 1 or 2 millimeters because it is from the deepest depth of the tumor, right? So anyway, that's accepted. And next, others?
And
Other
then from
factors?
biopsy, we can find the differentiation of the tumor, sir.
Okay.
For poorly differentiated tumor, the chances of net involvement is higher.
Yes,
Other factors
yes.
are for things like LVI and PNI, sir. Most of the time, the biopsy is very patchy or may not represent that part. So, on basis of biopsy, finding out LV and PNI is only in about 1/3 of cases. In majority of cases, they're not able to find a comment on LV and PNI. So, so ideally, if we can do a frozen section further from the primary, then we can comment more on LV and PNI.
So what are the most
Frozen-
important factors? That is what Dr. Neville is asking, which
So,
will make you
most important
decide that you
factor-
are going to do.
Some factors we will not know from the preliminary biopsy and the imaging. That's what I'm asking.
So, on the basis of biopsy and imaging, the most important factors are the depth of invasion, differentiation of
Mhm.
tumor, and the presence of extracapsular spreads. Other factors we sometimes can be based on biopsy, sometimes it cannot be. We cannot decide on biopsy, sir.
Akshay, you are not mentioning
Things
the
like
two
LV
most
or PNI
important.
or-
You are not mentioning two of the most important factors.
Tumor size. Tumor size.
and
Yeah.
the number
One
of
is the
level
site.
of
The second is a
sites,
T
the site and
stage,
the,
and third is a node positivity.
it's the number of nodes, number of levels involvement of nodes. If different
Node
levels are involved.
positivity, N stage. So three of the most important factors that you are going to see is what is the site, what is the T stage, what is the N stage. And then comes the other factors like differentiation or the depth of invasion.